Hi again. I'll try and be as brief as possible, as Dr. Hosni has a very interesting talk I'm actually very eager to hear. It's Pharmacomodulation of surface laser vision correction. Can we start? Okay. A history of excimer laser. As we all know, it was first developed by Dr. Srinivazan. He's been honored by by President Barack Obama. And in the mid-80s, Dr. Topical joined Dr. Srinivazan to write the first paper about excimer laser, and it was the first PTK by Dr. Zeiler. Where is he? Okay. And 1997, Dr. Topical he performed the first PRK, and of course Dr. Margaret MacDonald, she performed the first PRK over a seeing eye and achieving an actual refractive correction. And 1995, the FDA approval for the two machines, the Vizix and the Summit Autonomous. 1996, Dr. Dimitri Azar and the first LASIK. 2002, Dr. Palikaris and the first Epithelial. Actually, PRK stood. Okay, is it better now? Okay. Now the PRK stood the test of time with over 30 years of experience and around 25% of laser vision practice, according to a survey done back in 2016. We all know the advantage and disadvantage. This is old news evaluation. Of course, we all know that. I'll go through it quickly to have more time for what's more important lying ahead. Why does PRK has limited refractive range? To understand that, we have to go through corneal epithelial healing, which goes through the first phase, the lag phase, which is between the epithelial injury and the onset of the re-epithelialization. The adjacent cells, they start to migrate to cover the wound, and the secretion of two types of proteins, they are of utmost importance. The cytoskeletal protein, they constitute the structure of the epithelial cells, and the integrins, they are like the linkage between the epithelial cells and the underlying basement membrane and the stroma. And of course, the other phases, the migration, re-epithelialization, proliferation, stratification, and this is illustrated in this figure. If we apply this principle of healing to wound healing following PRK after photoablation, this is the first event to happen, which is the migration of the single layer of cells to cover the ablated area, apoptosis of keratocytes or the anterior stromal layers, followed by re-epithelialization of the remaining area, the remaining ablated area, and then keratocytes at the posterior stroma, they undergo differentiation and migration to the anterior corneal stroma. So actually, epithelial healing is the first to happen, limbal to central, basal to superficial, and as we noticed with so many histopathological papers and now with epithelial mapping, that there is increased in epithelial thickness with time. If you follow a patient did PRK over 2 years, you'll find that epithelial thickness is increasing over time. For stromal healing, as we mentioned, the apoptosis followed by differentiation and migration of the myofibroblast that originally used to be keratocytes to the anterior corneal stromal layer, and they lay down the abnormal collagen with so high percentage of dermatan sulfate, which is the most important cause of post-PRK or post-surface corneal haze. It has so many variables, and we should not forget this one, which is the duration of the epithelial defect. The longer we have epithelial defect post-PRK, the more the patient is prone for post-PRK haze. And this is dependent on so many variables like the intraoperative epithelial removal. How did you remove the epithelium? Did you remove it mechanically or by alcohol-assisted or transepithelial PRK or epithelial sparing techniques like the LASIK and the EpiLASIK? Let's start with the alcohol-assisted. The alcohol mode of action is to cause a splitting of epithelial hemidesmosomal junctions with the basement membrane, and it's both dose and time dependent. So actually it should be 20 by 20, 20% for 20 seconds. Any more than that, you subject the patient for more hazardous dead epithelial cells, even not the affected area by the alcohol or even the underlying stromal layers. The epithelial surface ablation, we stopped doing this, I think, so many years ago. They were thought to cause less pain by preserving an epithelial flap over the ablated area, but actually what it did is maintaining an plug of dead epithelial cells that hindered the peripheral epithelial healing. Of course, the transepithelial PRK is my treatment of choice for PRK for so many reasons, and one of them is that it shows a faster, significantly, I mean in my hands, a faster epithelial healing compared to the mechanical and alcohol assist. Now for pharmacological modulation with PRK, the use of Mitomycin C should be used for, yes, it decreases haze and regression, but it should be used cautiously when combined with alcohol, and we can even refer to using very lower doses, which is 0.002%. The usual dose is 0.02%. We might use this smaller, significantly smaller dose in lower myopia, less than 75 microns, because we all know that mitomycin may delay the epithelial healing. The non-steroidal anti-inflammatory, I used to follow a protocol of giving topical non-steroidal anti-inflammatory drugs till full epithelial healing, till I had few cases with sterile infiltrate. And even at the site, the website of the American Academy of Ophthalmology, cases reported of sterile infiltrate or even maluse of non-steroidal anti-inflammatory caused even some cases of corneal melting. This is on the American Academy of Ophthalmology website. So I stopped using non-steroidal, and I started using even topical corticosteroids from day one. You may refer to lesser frequency or even less potent, pharmacological drugs like the fluoromethylone, if you feel more comfortable with this. And when full epithelialization, you can give the full dose of the topical corticosteroids. We all know the problem of using corticosteroids for a long time, and you may use this drug for a long time with surface ablation when compared to LASIK, up to even 6 weeks. So you should be very careful of steroid-induced glaucoma. How to promote epithelial healing? This is very important. The standard protocol that we all follow is the bandage, contact lens, preservative-free lubricant, but some might go even more aggressive with their treatment with resistant epithelial healing, like the use of scleral lenses, punctal block, autologous serum. Some drugs actually that are not available in the Egyptian market, like the regenerative agent Casicol 20, all thanks to Dr. Hosni, who introduced me to this topical drug. Actually, it's not available in the Egyptian market, but it's available in other Gulf areas and some European countries. It was introduced in 2015 in one of the American Academy of Ophthalmology meetings, and this is a biodegradable nanopolymer. It mimics the effect of heparin sulfate, so it promotes epithelial healing. However, in 2020, the U.S. clinical trial of this drug was terminated, and the reason for that was poor patient recruitment. So up to my knowledge, it's not FDA approved. Another drug is the Nexigen, which is prevents the connexin 43, which is important for neural crest and cardiac development, and again it promotes the nerve regeneration. The last thing I'm going to mention is the dual polymer of hyaluronic acid and hydroxypropyl GUR. Both of them were tested in one study that was published in Journal of Ocular Pharmacology. They used 6 types of topical drugs, all of them containing hyaluronic acid except for one that contained this dual polymer. It was an experimental study over mice eyes, and the results favored the dual polymer with the least area stained with fluorescein after 24-hour examination. The idea for all in vitro and in vivo studies about this dual polymer, they concluded that heparin it promotes healing, and the hydroxypropyl GUR it changes up to a gel when subjected to the tear pH, and it acts like the mucinous tear film layer, which helps retaining the hyaluronic acid, which promotes actually the water retention and surface hydration, and promotes healing. I hope I made some time for your presentation.